Next, I'd like to introduce two of our pharmacogenomics pharmacists. So Aaron spoke a little bit about what pharmacogenomics is. And this is a revolution that is happening very, very quickly. These guys are going to describe this to you. But a blood test, a simple, very cheap blood test that you can take one time in your life that can prevent a number of adverse effects from drugs, that can tell you what the best drug for you is in many, many settings. And so I'm really proud to welcome Mark Kirkikis. Mark joined the Ochsner Pharmacogenomics team. In fact, Mark was the Ochsner Pharmacogenomics team for a number of years, and takes information that I can guarantee you none of our thousands of doctors really can understand, and boils it down to a single treatment recommendation. And then last year, we doubled the size of our pharmacogenomics team when we added Serena Mitali, who completed her training at Mayo Clinic in pharmacogenomics. And together, they form our team, which is just super heroic. So please.
Everyone thinks I favor Dr. Matrana, but that's not exactly true, okay? You can see I put the biggest draw in the smallest room. That was a mistake, but I'm going to use it to my advantage to tell people that, you know, he's not our favorite scientific advisory board member. So, but I'm really sorry that everyone's standing. I apologize. It won't happen again next year, so sorry to interrupt you.
Yeah, thank you. And thank you for having us back for a second year. I think it keeps getting better. And it was great to have us follow Erin, because it's a great lead into what we're going to be speaking about today. We're going to specifically talking about that little niche that she was talking about, Ochsner PGX. And if anybody went to the keynote speaker yesterday with Scott from Google AI, he had one slide on it, and I appreciated the shout out right up until he said controversial. And I'd like to put a few of those things to rest, but neither of us have any financial disclosure report, unfortunately. We'll try harder next year, right, Serena? Yeah. So we'd like to talk about the introduction of PGX and its applications, kind of from the ground level, how we did it, how you can do it, identifying those applications specifically through oncology. We'll go over a couple of the other areas that you will see it, and then the understanding of the clinical rationale for our dosing recommendations. So we are pharmacists. We're going to try not to get in the weeds. A lot of times as pharmacists, we talk about kinetics and half-lives and metabolisms, and that's all great, but we want to kind of pull back a little bit and talk about the bigger picture of things today. Some of the abbreviations you'll commonly see. Hopefully I'll try to refer back to these a couple times. You've already seen this slide. Luckily, that's okay. I was like, I know where Aaron got that slide from. It's simply that we're going to take somebody's DNA and then we're going to boil it down to how their DNA affects medication metabolism, not the other way around. So not the somatic testing that I've heard essentially all weekend, which is great, but a lot of that germline testing that individually how it can affect a single patient. So most studies are done by, birdshot, essentially. We're going to give this dose, 10 milligrams to 1,000 patients, and decide that this is the best dose on average for all these patients. Well, what if we did the opposite way and said, what about this patient's metabolism specifically? Can we predict a dose that's going to be best for them before we go down that path? And in doing so, we pass over this current state of trying drug A, drug B, drug C, and then finally get to drug D on a trial and error approach. And drug D may be the same drug on different doses. It could be a different drug in the same class. It could be a different class altogether. If we go to that future state of precision medicine, we can go straight to drug D by reducing side effects, by reducing the time it takes to get to the right dose, and then essentially patient overall compliance with the medication. So we're going to see patients be a lot more adherent to their drugs, which is a big sticking point for a lot of pharmacists. So we are under the precision medicine umbrella. Dr. Matrana is our fearless leader at Ochsner. We are just kind of a subset of that. So our goal is, yes, we're going to potentially have a financial benefit to patients, to health systems in the long run. But our goal as frontline providers is to improve medication safety. I think that's from the get-go what our kind of mantra has been, and that's helped us lead through the initial stages of this project. So I am not a geneticist. I am a humble clinical pharmacist. I really didn't have any genetic background. In fact, my boss, Catherine Oliver from Ochsner, approached me and said, "Hey, Mark, we're starting a pharmacogenomics program. Would you like to come start it for us? Help, lead that?" And I said, "I would love to. What's pharmacogenomics?" And the last, I think, genetics class I took was the summer of sophomore year in college. It wasn't even a real class. It was a summer class. And I think I made a B+. So if I can do it, you can do it. It's essentially what we tell our other pharmacists as we're rolling this project out is it is just another data point. It's another liver panel. It's a lipid panel. It's the hemoglobin that you're going to be assessing before you start an anticoag. It's a lab that you can take to help make the best drug decision. And that's how we have built it at Ochsner. So we see patients coming in with their genotype, right? One from mom, one from dad. You get a star allele is typically what we see it called. For example, DPYD is the gene that we're talking about here. Aaron kind of already alluded to it. We'll talk a little bit more in depth in a minute. But you're going to get one from mom, one from dad. So a star 1 and then a star 2A. From this genotype, which forms the diplotype, you can actually get a phenotype. How your body actually will metabolize that medication. Are you normal? Are you rapid? Are you less than normal, which we would consider either intermediate or poor? And then from that, we would see that this patient is an intermediate metabolizer. From that, we have clinical action that we can take. What do the guidelines say? From the guidelines, we have multiple international and national bodies that kind of come with a consensus. And from that dosing recommendation, we decided that we're going to reduce it by 50%. So before this patient even is considered for this drug, we already know ahead of time, if we're going to start something like this, we're going to reduce it by 50%. And from that, we're seeing really good safety benefits from that. So you're thinking, well, how common is this actually? We have our own socialized medicine in this country. Europe doesn't get all the cool ones. We have the VA, which did a study a couple years ago, over 7 million patients. They found that 99% of their patients carried at least one actionable gene, which we call a pharmacogene variant. So if a patient were to receive a medication of one of the ones that we have data about, 99% of them would either be required to reduce the dose, increase the dose, or avoid that drug altogether. And that was over about 7.7 million patients. Well, of those 7 million patients, over half of them had actually received one of those drugs. 15% received 2 drugs, and over 10% received 3 or more drugs of level 1 actionable evidence. So it's out there. We just haven't been looking for it yet. We could have made recommendations on millions of patients if we had had that information at the time. Like Aaron said, like Dr. Matrana said, it is a simple blood test. It follows that patient around for life. It's a DNA test. It never changes. So we tell our patients, our providers, think of it as like a Ronco oven, like set it and forget it, like order the test and then don't think about it again until it's actually time, until you are alerted that there is a drug interaction, a gene drug interaction that's going to alert the provider at the time of ordering. Other actionable medications, the FDA has package inserts for over 200 medications with PGX specific data. CPIC, which is our governing body that we follow in the United States, has drug gene pairs for over 35 guidelines. And then over 10% of the top 200 drugs that we see have package insert references. It's out there. We just need to be applying it. These are some of the CPIC guidelines. So CPIC stands for Clinical Pharmacogenetics Implementation Consortium. They are the latest and greatest, brightest minds in not only this country, but internationally, that pulls together all the literature and decides that there is enough data to provide recommendations or non-recommendations for specific drug gene pairs. And I say non-recommendations because they may say that, oh, there's a lot of buzz around, I say MTHFR, for example. We hear about that one a lot. We don't really know what to do with it. They review the literature and they say there is not enough data to take actionable clinical recommendations from this yet. So they do produce some of that too. So we see all the different areas that we can see follow around a patient. I boxed oncology because obviously this is what we're going to be focusing on today, but it doesn't apply to just oncology. The body doesn't care that it's a cancer patient, but they're about to receive Plavix because it still is affected the same way. We see patients come in with PGX results because they have cancer, but they were admitted to the ED for chest pain with an NSTEMI. At 3 a.m., our provider tries to give them Plavix because they're going to be rushed to the cath lab. They get an alert that says, don't give Plavix. They're a poor metabolizer. They're not going to activate the drug. The provider at 3 a.m. with no additional assistance says, okay, I'll just give them Brilinta. A crisis averted. The patient goes to the cath lab with the right medication and we haven't done necessarily anything else. It's another lab that can be acted upon at the moment of ordering. So the benefit to the patient, obviously, optimize your current medication regimen. Make it more effective for the patient. You're minimizing drug toxicities and predicting patients who will respond to certain medications before they even take them. To the hospital, you're identifying the most appropriate and affordable medication before wasting time and money going down a pathway. You're also reducing ADRs earlier in treatment by preventing hospital lengths of stay, or reducing hospital lengths of stay, reducing hospital admissions, and reducing ED visits. And we are seeing that. We're collecting data, specifically our DPYD patients that we'll be going over in a little bit. But essentially, there is literature on all of these drug gene pairs. We're seeing it in our behavioral health medications, our SSRIs and our SNRIs. Patients are really hard to get down for antidepressant therapy. So if you can eliminate half a class before they even start, you're already benefiting for the patient. And they're more adherent to their medications because they're working for them. The time of the test changes its value. I want to say that again. The time of the test changes its value. I want you to get it for you and for the patient when you're young and healthy and don't care about medications, as opposed to when you're 75, you tried all these other medications over the course of your life. You realize that you're allergic or non-responsive to certain medications, and then you're realizing why you had bad responses to those to begin with. I want you to get it preemptively, where you're a healthy patient with no real need to get it because those results are going to follow you around for the rest of your life. They're going to live in your chart and follow you around. So from the get-go, your DNA never changes and you can have the benefit over the course of your life. The PGX in oncology at Ochsner has been our backbone from the get-go. So we have implemented it from the pilot that we started with our DPYD patients that Aaron talked about. This was kind of our standing for building our program from the start. Over the last, we started in March of 2022 with our full panel testing of 30 genes. We've done, if this slide could be updated week by week, we're quickly approaching 3,000 tests that have resulted in our system. About 2/3 or approaching 70% were oncology providers that have ordered them, so oncology indications, but not always. And we're finding benefits that are non-oncology reasons for oncology patients. We see a lot of psychiatry uptake. Primary care is really starting to take it under their wing and say, we can put this into play because we're having more time if, hopefully we'll see that AI is taking some things off their plate, but primary care is buying into it as well. Our test panel is 30 genes. They all result as discrete results in our Epic system. So panel testing is the way to go for us. We're not doing single gene testing. with a single gene test, you're going to pay just as much as for a panel test. And like Dr. Matrana said, it's relatively inexpensive. We're finding that the majority of our patients are paying less than $100. Most of them are a $0 copay. Because of the amazing work that CAGLA has done, we have fully integrated that into our system. DPYD testing was implemented for required testing prior to fluoropyrimidine therapy starting in July of 2022. Serena's going to go over a little bit of data that we're seeing, why we decided to make that kind of a staple. And then we'd like to go over some of the select genes for chemotherapies and supportive meds for oncology and why that's so beneficial in those patients. So I'd like to ask Serena to come up and take over some of the more clinical information.
All right. With that in mind, let's go ahead and get right into it. So just starting with some brief background about DPYD and fluoropyrimidines. So DPYD, it's an enzyme. It's primarily responsible for the breakdown of fluoropyrimidines. So it takes that active medication, brings it down to inactive metabolites. So this gene encodes the enzyme. The enzyme is responsible for 80 to 90% of all inactive metabolites resulting from 5-FU. If we are to see patients who inherit a reduced function copy, like Mark was mentioning, they can either inherit one or two of those alleles. If they are to inherit one of those alleles, we see a decrease in the function of the DPYD enzyme. And this results in less of those inactive metabolites being generated, and we see higher concentrations of the cytotoxic metabolites. So how does this translate clinically? We have seen, so just here at Ochsner, there's around 5% of patients who will carry one of these genes. And this is pretty common to what we see in our guidelines. So they report that around 5 to 10% of all patients will carry one of these copies of a reduced function enzyme. So when we look at total populations, this is the number of patients we are concerned may have these negative outcomes from fluoropyrimidine therapy. Literature has shown that if patients are given full traditional doses of 5-FU-based therapies or capecitabine, around 50 to 80% of those patients will experience a severe toxicity. These can look like things like febrile neutropenia, fevers, mucositis, severe nausea, vomiting, diarrhea, and in up to 2 to 4% of these cases, they can actually be fatal. And through a meta-analysis, it looked at 35 different studies, including up to 13,000 patients. They found that in patients who had normal wild type, normal function of DPYD, they saw 14 deaths over all of that data. When looking at just the patients who had this variation, there were 566 of them, and there were 13 deaths. So overall, we see almost a 25-time higher risk for these patients that carry variants that are given full doses of DPYD. So with that in mind, that's really why we tried to spearhead our efforts with using PGX in oncology with DPYD, because of the severe negative outcomes that we have seen in patients. So again, with some of the evidence, obviously we have a lot out there looking at safety, and we find that when we see patients who carry one of these variants, by giving them an initial dose reduction of 50%, we see a huge reduction in those toxicities. So we see equivalent rates of these side effects as we would with our wild type patients. Additionally, if you were to carry 2 of these variants, we would recommend an even lower dose, so only using 10% of a dose or avoiding the medication altogether. So while it is much more rare to have 2 copies of this variant, when patients do have those 2 copies, we would avoid the medication altogether in most cases. So there are various guidelines in addition to CPIC, which Mark mentioned is traditionally all our hallmark guideline that we look to when we develop our recommendations. But there are multiple international guidelines as well as just our oncology guidelines that we look to and consider when making these decisions. So one area of potential controversy is in that the NCCN is not currently following our CPIC recommendations. So, stating that all patients should be genotyped for this and should be dose reduced should they have it. Where some of this controversy comes in is they do identify and look to all of the safety data. They say, we see that, we identify with that. But what we continue to be concerned with in the oncology community is, are patients still going to have the same level of efficacy with their chemotherapy if we're going to use these dose reductions? And that's really where one of the biggest barriers has been traditionally. More data continues to be available, especially as our European counterparts are requiring this, are using it and posting and publishing their data. So in 2023, there was a matched pair analysis done using genotype-guided dosing within the Netherlands, since they use a lot of PGX there. And what they found is that when they dose reduced their patients who had DPYD variants, the dose reduction did not negatively impact progression-free survival or overall survival. And this was in a study of 156 carriers of the gene, as well as 775 controls, prospective design across multi-centers. So the data does continue to come out and show support in efficacy with using these dose reductions. But unfortunately, here in the US, we're a bit behind, and the FDA looking to NCCN for some of their recommendations. Because they're not available in NCCN, that has led to somewhat of a lag in the FDA as well. But here at Ochsner, we are using the dose and we are not finding decreases in efficacy as of yet. So for our next gene drug pair, taking a look at UGT1A1 and irinotecan. Irinotecan is another commonly used chemotherapy, typically for our advanced colorectal and pancreatic cancer patients. So irinotecan is actually, its active metabolite, SN38, is broken down by UGT1A1. So similar with DPYD, if patients have reduced function of UGT1A1, it leads to less generation of inactive metabolites, and we see higher concentrations of the active metabolite. So clinically, we see these patients are at much higher risk of toxicity since they're not able to break down the medication as well. And for patients who inherit 2 copies of the reduced function, or poor metabolizers, we see up to a 70% reduction in their ability to clear SN38. And this translates into an 8-time higher risk of having toxicities, particularly at higher doses. So what are our clinical recommendations that we're currently following for UGT1A1, poor metabolizers, and irinotecan? So currently, we are recommending using a 30% dose reduction in these patients. And what we found through studies is that when we do this dose reduction, we see the incidence of severe toxicities greatly decrease. So from 13% to 56%, as well as with chemotherapy-related hospital admissions, we see significant decreases across studies. So we don't currently have CPIC guidelines as of yet. They are currently reviewing the data and putting together a new guideline that will include UGT1A1 and irinotecan. So we will hopefully be seeing that within a year or 2. But our European counterparts, so DPWG for our Dutch, the AIOM is the Italian Medical Society, and then RNPGX is French. So all of these other international guidelines are currently recommending those dose reductions. And the French guidelines even go as far as to say if patients are going to be considered for high doses of irinotecan, it is essential that we receive this testing to prevent these toxicities. And the FDA labels, they don't give a specific dose, but they do at least tell us to consider dose reduction. So even without CPIC in the US, we do have some FDA guidance. And then the last gene drug pair I wanted to talk briefly about is with tamoxifen and CYP2D6. I know we've kind of talked about tamoxifen a few times today already. As I'm sure we're all familiar, this is one of our first-line agents that we use in patients with breast cancer who are ER positive to help them keep remission as long as possible. So a little bit different than we saw with UGT1A1 and DPYD, CYP2D6 is actually responsible for the conversion of tamoxifen into endoxifen, and endoxifen is one of the main active metabolites that exerts its chemotherapy effects. So when we see a reduction in our ability to turn on the effect of the medication, we can see less concentrations, and this can correspond to a decrease in efficacy. So we do currently have CPIC guidelines looking at CYP2D6 and tamoxifen. They really harp on, we're seeing these lower concentrations. So we're looking at pharmacokinetic data. When we look at the amount of endoxifen with patients who are poor metabolizers, we see significantly lower levels, and this is across the timeline of treatment. So what are our clinical recommendations? So if patients are poor metabolizers, we are recommending to use an alternative since they are very likely to not have benefit from the medication. If patients are intermediate, meaning they only carry one of those reduced functions copies, they will also recommend to use an alternative. Alternatively, you could consider using tamoxifen at a higher dose because there are studies that show if you boost that dose, it can get patients to the level of endoxifen needed to exert its effect. Our international guidelines, we have Dutch, Canadian, and French. The Dutch and Canadian are essentially mirroring our CPIC guidelines, and the French actually don't provide a recommendation. And one area of controversy with that, additionally with the FDA, is one of our main barriers that we find in pharmacogenomics is we get a lot of data looking at pharmacokinetics. We understand that when a patient isn't able to metabolize something, we see lower levels of that metabolite in the system. What's really difficult is being able to translate this into our clinical outcomes for efficacy. So a lot of the times we can see that safety, but it's harder to get the evidence for the efficacy. So at least for now, the FDA, they say, yep, we understand, we see this change in levels with our active metabolite, but we're not currently making recommendations based on that. We do continue to have more and more prospective study designs coming out that looks at this data, and our international guidelines as well as CPIC do find that we believe the evidence is strong enough to make these dosing recommendations. But depending on which organization you look to, there is not one standard. So that can be where it becomes controversial. But at least here at Ochsner, we are following CPIC and we are promoting having our patients have the best chance of efficacy with these dose recommendations. And then lastly, just really wanted to quickly touch upon some of the other areas which we can use our pharmacogenomics with oncology patients. So as Mark alluded to really well, in our SSRIs, SNRIs, many different medications for psychiatry are impacted by PGX. We see this in pain management. So with tramadol and codeine, some patients aren't able to activate the medication. And we see obviously many patients with nausea vomiting potentially using ondansetron. And for those patients, if they have very fast metabolism, they may never get the benefit they need for that nausea medication. And so we can recommend alternatives in these cases. So as we can see, there's a lot of information out there that we can use for our patients. And at Ochsner, as we have our 30 gene panel, whenever we have a patient who has this test result back, we are not only looking at optimizing their oncology therapy, we are looking at our patients as a whole for all of their different medications that they are taking or may be taking in the future. So for future directions, obviously our goal in precision medicine is to continue optimizing our cancer therapies for our patients. We are continuing to perform research here at Ochsner with our DPYD and UGT1A1 dose reductions. And as I mentioned, just looking at patients as a whole. All right, thank you. Yeah.
Currently, is the testing patient only physicians right now, or patients or consume as consumers of healthcare, can they independently request that they be tested for these various genes?
Yeah, definitely. So, at least within the oncology space, for any patient who we're considering starting on 5FU, our providers are putting in that order automatically. In a lot of our other areas, if a patient has interest in the test, they can talk to their provider and their provider is able to go ahead and put in that order for them. So,
Patient wishing to have gene testing, how can they find it on your sign up? Is it a patient patient will request blood test?
yeah, just a general PGX. Yep. Yep, just one test, all the genes. That's the $1 million question. So at least here with our advocacy work in Louisiana, we do have that covered for our, I believe it's Medicare and Medicaid patients. Yes. So we work very closely with our third-party lab, and if the patient needs, if it's going to be more than $100, the lab will reach out to that patient and contact them. Our laboratory also works with the insurance companies, and they have their own methods that they use to try and lower those costs for patients. We find that on average, patients pay around $100 or less, which is why if that cost is expected to exceed that, the lab will reach out to the patient with other options. Yeah, one of our great things that we're trying to look at too is what are those patients who will benefit the most from testing. So when we look at patients, what's that population where we're able to make the most actionable recommendations that helps to either prevent toxicities or improve efficacy?